Today we're talking about blood vessels. So last time we talked about the last couple times we talked about the heart and we've talked about the blood, so we know what blood is, we know what's pumping it. So now we're just going to talk about the kind of the highways that carry it. We also already hopefully know that we have three major types of blood vessels. We have arteries, veins, and capillaries. Arteries carry blood away from the heart. That's it. Okay. Oxygen content doesn't matter when we're talking about arteries and veins. It's truly just direction of the blood flow. Away from the heart, it's an artery. If it's towards the heart, it's a vein. Okay. Now, um, all blood vessels are going to be composed of three layers, or what we call tunics. Okay. We have the tunica intima, which is the innermost layer, the tunica media, which is the middle layer, and the tunica externa, which is the outside. Okay. Uh, there are going to be differences between arteries and veins in all of these. Okay. Now, the tunica intima in both arteries and veins and capillaries is going to be composed of what we call the endothelium, which is essentially going to be a single layer of simple squamous epithelia. Okay. Um, so we have cell touching cell, touching cell, touching cell, and we basically have a single layer thickness right here. Now, uh, and then we have the basement membrane of those simple squamous cells. That's going to form our tunica intima. Now, the shape of that tunica intima is going to be a little different between the arteries and veins. Arteries is going to be much smaller, typically going to be circular. Veins is typically going to be a little bit larger and sometimes will be kind of oval in shape, but that's because it just doesn't have a very specific shape it has to follow because it's not going to be under load and under pressure like the artery one is. Because the artery one is under pressure, it's going to equalize that pressure over the entire surface or inner surface of the artery. And because of that, the most uh, energetically stable form of that is for it to turn into a circle. Okay, just like if you blow up a regular balloon, it's going to turn into a circle. Okay, just because that's the most energetically stable form. Like there's equal pressure in all directions. Okay, so that's what's going to happen here. So we're going to form this kind of circular lumen here. Now, superficial to that, the next layer we have is the tunica media. So that's going to be this middle layer. The middle layer here is very different between our artery, which is here, and our vein, which is over here. Both of them have this layer of muscle, but notice that the artery, it has a much, much thicker layer of muscle than does the vein, okay? Um, that's because we can use that muscle for two things. We can use that muscle to act as a source of resistance within the vessel. So like remember that muscle cell is stretchable. That's one of the things that we use muscles for is because it can be stretched. So we use a bunch of muscle here in the artery because this is under load. So we need something that can stretch. Because every beat of the heart, we're pushing something like half a liter of blood out, which is a lot. So because of that, we have to be able to deal with that force. So we need something that there's there that's going to be able to deal with the stretch. Now, just based off of that, you can see that the arteries are probably going to have more stretch placed on them than will the veins because we have a much thicker layer of muscle. But in addition to the muscle to help deal with the stretch, arteries also are going to contain a couple of sheets of connective tissue, or what we call elastic lamina. So lamina just means layers. So we have an internal and an external layer of elastic lamina here. Okay. Now, these are essentially going to be extra layers of elastic tissue in addition to the muscle. Okay. Now, this means that we have even more ability to deal with stretch and then that we rebound and go back to our original shape. But now this raises the question then of why do we have muscle here at all? So why do you think we have any muscle in the vessels whatsoever? Like, why don't we just use the elastic tissue? What does muscle do?
Like because I know you said it like stretches and stuff, and
Yeah, it can be stretched, but what's the opposite of a muscle stretching?
like tearing.
Not tearing. If it's tearing, it's doing something different. Like
Because it can.
it does heal itself. It is much better at healing itself than connective tissue is. So the elastic tissue probably wouldn't repair itself very well if something did happen to it. That's probably part of it. But also it contracts, right? So muscle cells can contract, which means we can contract these muscles, right? So if we can contract these muscles, what's going to happen to this opening? It gets smaller. So we can utilize the muscle and the tunica media of the arteries to control the flow of blood. Okay, we can constrict to put more pressure on that blood, make it harder for the blood to move through it, or even constrict it more and then stop blood from moving into particular places. So we can regulate blood flow to particular tissues and things like that via either constricting or dilating these arteries using that smooth muscle. Does that make sense? Okay, so that's why we're using the muscle here, so that we can exert some control over the blood vessel. Okay, so we can vasoconstrict or we can vasodilate. Now, finally, we have the tunica externa. So the tunica externa is basically going to be this outermost layer. It's very, very thin in arteries. It is way less thin in veins. Okay, way less thin in veins than it is in arteries. So it's much thicker over here. Now, both of these are going to have little tiny blood vessels called the vasa vasorum. You just can't see it because the word's tiny. Called vasa vasorum, that are essentially just going to be the blood vessels of the blood vessels. Okay, the blood vessels of the blood vessel walls to make sure that these cells in the blood vessel walls are able to stay alive and do what they're supposed to do. Now, veins are not under pressure, so their inside is also going to be a little bit different. Our medium to large veins are all going to contain, or even small veins, will contain these valves, okay? And just like in the heart, the valves are going to be here so that we can make sure that the blood is only ever moving in one direction, okay? So blood will get pushed up here, and then when the pressure falls off, it'll kind of pull up into these little valves, but this way it doesn't go back down. It just can keep kind of getting pushed up. Does that make sense? All right. Now, this finally leads us to the capillaries. Capillaries are different. Capillaries are basically going to be an endothelium and then a basement membrane, and that's it. Okay. They don't have any of these other things going on. Why? Well, because this is where we have stuff going into and out of the blood. Okay. If we have more layers of stuff in the way, that's going to inhibit our ability to get things into the blood that need to get in. That's also going to inhibit our ability to get stuff out. Okay. So capillaries are going to be very, 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 very small and not have anything in the way. And we're going to talk about some special groups of capillaries here in a second. So here we have an actual micrograph of an actual artery and a vein. Notice how much thicker the walls of the artery are when compared to that of the vein. Okay, so much, much thinner in the vein than in the artery. Notice how much also more circular the artery is. The veins tend to get flattened out a lot. Also, because it's an artery, see how it's kind of full of blood? There's not any negative space in there. Whereas we do have some negative space in here in the vein. That's because the size just not under as much pressure. But we can also see the kind of puckering of the endothelium here, the tunica intima. We can see how thick the tunica media is, and then also the tunica externa is out here. All of this basically that you're seeing right here is basically just all tunica externa. Now, capillaries, once again, very, very different. Now, we do also have different classes of arteries that we can control in different ways. For our arteries, we have elastic arteries, muscular arteries, and then we have arterioles. Okay. The elastic arteries are going to be the largest of our arteries. These are going to be the ones that are closest to the heart. So this is going to be stuff like our aorta, even going all the way down to like our iliac arteries and stuff like that. But these are big. They're carrying massive amounts of blood that is under massive amounts of pressure and is moving incredibly fast. Okay. And because of that, these things have to have an incredible amount of stretch. Okay, so these just underneath our tunica intima, we're going to have a big layer of elastic tissue. And you might look at this and say, okay, that's a lot of muscle. But keep in mind that in this case, the muscle is all interlaced with elastic fibers. Okay, so you have essentially a bunch of smooth muscle cells kind of all working together. But wherever there are smooth muscle cells, you've also got these little bands of elastin just kind of interlaced through all of them. Okay, so basically, wherever there's muscle in this case, there's also a ton of elastin, which means they are incredibly stretchy. Okay, that way they can deal with all of the crazy forces that your heart is putting on them. Because once again, basically every time your heart beats, it's moving about a half a liter blood. Okay, so that is a lot. Okay. And it's having to go through a tube that's about that big around. Okay. Uh, which means it's going to be shooting through that tube with some pace. And also that means the walls of that have to be able to deal with that force. So they have to be able to bounce back or like absorb that force and then recoil. Okay. So the only way that we can do that is by essentially mixing in all of those elastin fibers in there to help them do it. Now, as we get a little further away, we get into our muscular arteries here. This is where we get those nice distinct bands of internal and external elastic sheaths or elastic laminas. Um, these we can start to open or close to allow blood to get to particular areas of the body or prevent blood from getting to particular areas of the body. And then finally, we get down to arterioles. Okay. This is where we're going to start to allow blood to get to particular capillary beds and things like that. So we can get a lot more precise with our control and our arterioles. Here, we've actually lost most of the force in the blood, so we don't need nearly as much elastic tissue in all of this stuff. So you're actually not going to find those distinct bands. At this point, we're basically just some smooth muscle underneath the tunica externa. Veins, it's actually a lot more simple. They're basically just tunica intima with some valves in the small to medium sized veins and on up. The large veins are basically the same as the small ones. They're just bigger tubes, like slightly thicker tunica externas, but that's really about it. They still have valves and all that fun stuff. Now, our elastic arteries, like I said, these are the ones that are going to have the largest arteries. So they're going to range in diameter from 2.5 to 1 centimeter. So to give you an idea, 2.5 centimeters is about that big. Okay. So, and that's just the diameter. So imagine a circle about the size of one of the joints of one of your fingers. Okay. That's a pretty big circle. Like we're talking like inside my finger, literally that big. That's a blood vessel. We don't want that to break. Okay. Thus, we have the elastic in there. Okay. Now, there are certain things that can lead to what we call atherosclerosis. Okay. So, stuff like smoking, really high fat diets, stuff like that can cause the blood vessels to harden, which means that elastic tissue isn't going to work as well. So, they're not going to be able to absorb as much force. When that happens in something like the aorta, these muscles then can get torn. Okay. So, you might go from the blood vessel looking like this to where it gets a tear in the wall and it looks like this. Okay. We would call this a dissection. My father-in-law actually had this happen to his aorta from here to here. So he's got a 7-inch long stent moving through his descending aorta to protect it from this because of this big tear. It was very, very close to him just bleeding out of his aorta and dying. And this happened during like 2 weeks before my wife graduated from CRNA school. So he had to watch her CRNA school graduation on TV. Fun times. Uh, but yes, so these are very, very large. Some of these largest, or like some of the other ones that we consider large arteries, still have a centimeter of diameter, which is about the size of the end of your finger looking end on. That's still a pretty big blood vessel. If you were to cut one of these and just have it start pouring blood for something like the aorta or one that's this size, it would literally hit that wall over there. That is how much force we're talking about and how much pace. Okay. It's a water gun. Okay. Why? Well, because it's conducting blood from the heart and it's trying to get it somewhere. Like the ones here in the iliac artery, like that blood is still shooting its way and has to have enough force to get to the ends of my toes. So it has to literally be a water gun of force to be able to get it down there because of all the resistance and stuff in the way of all those little vessels. Okay. So that means we have to have lots and lots of stretch in those things. Now, once we go from those larger vessels in that kind of centimeter range, we're going to go down to about 1/3 of a centimeter. So a lot smaller. That's going to be actually that's not about like that. Okay. So the end of that little rod there is going to be pretty close. So fairly small. Okay. Actually, 1/3 of a, oh, that says 1/3 of a millimeter. That's not even saying 1/3 of a centimeter. So even smaller than that. So 1/3 of a millimeter is like we're getting tiny at this point, right? So that's like truly the end of your fingernail. Okay. Um, very, very thin. Okay. These will still have some amount of uh, elastic tissue, but by this point, once we've gotten to vessels that are that small, these vessel walls have already absorbed the vast majority of that energy. Okay. Things are slowing down a lot. Okay. Things like your aorta, your iliac trunk, all these kinds of things, these are freeways of blood. Like we're moving massive amounts of blood really, 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 really fast because it's got a lot of stuff and it's got a lot of places to go. Once we get into vessels that are this size, they're not going to nearly as many places. They're a lot smaller. These are your backcountry roads at this point, where you're just kind of cruising along, where there's not a lot of pressure. Okay, so because of that, we don't need nearly as much stretch. Instead, we need control. Okay, that's where that smooth muscle comes into play, so we can constrict or dilate to adjust where the blood is going, so that we can do a better job of sending places, or like if something needs more blood, we can dilate so we can get more blood going to those areas. If we need to constrict, we can constrict to say, hey, let's not send as much blood to the kidneys or something like that because we're running. Let's instead dilate the blood vessels in the muscles and constrict the vessels in the kidneys. This is kind of where that stuff is going to be occurring. Does that make sense? Then finally, we get to the arterioles. These things get tiny, okay? Uh, to the point where we actually lose one of the tunics in our smaller arterioles. Um, these we can regulate regulate size. But when we're doing it in this case, we're usually doing it to regulate just kind of overall blood pressure. Okay. That's because while these are the smallest, so the smallest in diameter, we have a lot more of these than we do the others, which means if we constrict all of these, we can raise the overall blood pressure in the system by creating more resistance. Okay. Or we dilate these and decrease resistance and stuff like that. So we can actually regulate blood pressure by kind of messing with our arterioles. So when we look at these, we can see that this is much, much smaller. This one's zoomed in far more. Like if you could see the bottom one is 7 times closer than these other two. These two are at the same magnification. That should tell you how big this blood vessel is. This is 100x, this is 100x. It's literally 5 times the size, if not bigger. Okay. It's also huge. And see all those little tiny black lines running through there? Like, or see how it's kind of dark? Okay. That's because that's all elastin just working all the way through all of here. This one, you have a separate band of elastin here and a separate band of elastin here. Uh, Here, let me just blow this up and make it a little easier to see. Oh, yeah, that works. So we can see the tunica intima is kind of all contracted on itself. That's why it's all wavy. But also we can see this nice little line right here where everything's nice and parallel, and this dark line here and a dark line out here. That's our elastin in that case. Whereas up here, we don't see distinct regions of dark lines. This whole thing, they're just interthreaded in between. So once again, atherosclerosis is something we hope to avoid because this is basically going to cause the lumen to get smaller, so it's going to do things like increase pressure, while at the same time, it's kind of hardening some of those elastic tissues, so they're not going to be able to dilate very well, or be able to deal with those forces, which means they can start to kind of break apart, which is real bad. Okay. Once again, typically going to be more common in males than in females, is because males typically are going to have higher blood pressures anyway, due to testosterone and all that fun stuff. But stuff like smoking can vastly increase the rate that this occurs. Uh, this person, my father-in-law, smoked between 1 and 2 packs of cigarettes a day for the last 30 years. Uh, so that's what was to blame here. His diet, actually not all that bad. His blood pressure's not all that high. It spiked, of course, during this event, as one would imagine, thus the cause of this. Uh, but nothing really in particular. Like he didn't have big blockages or anything like that. Most of this was truly just because of hardening, because of years of smoking. That's it. And only within the last 6 months did he stop smoking. Whereas we have graduated from grad school for what, 8 years now? So it took him that long to finally learn his lesson. So fun stuff. If this happens in your heart, if you've ever heard of someone having a bypass, it's where basically we have a blockage in a vessel. So say we have our blood vessel here, and say we have some plaque buildup on the inside here, and we're not having very much space to send the blood through. That means we're gonna have much increased pressures here. So what they'll do is they will, like, so say we have our heart here and say our blockage is right here, they'll just basically make like a little shunt to go around it and give the blood somewhere else to go, like a different pathway. So that's what we mean by bypass. So like I mentioned, I think last time, my granddad had 2 different quadruple bypasses. And this means that they did this on 4 different places. On his heart once, and then on a separate surgery, they did it again. I'm surprised there was anywhere to go. But yeah, fun stuff.
There's more about it, right? For like whole bunch of different.
Yes, you can bypass in lots of different places. You can do so. A stent is essentially where they go and they put a mesh inside the vessel itself, the vessel that's messed up. So that's what they did with my father-in-law. So the parts where it was messed up and torn, they went in and they basically put a big stent, which is essentially like just a plastic mesh on the inside of the blood vessel. Or another thing that they can do is they do another bypass, at which point, like anytime you have a blood vessel here and say there's a blockage right here, they can just go in with a little bit of blood vessel and go here, just build a little pathway around it. But the fun bit is that if this blockage happens fairly gradually, your body will sometimes do this on its own. We'll build our own little, we call these anastomoses. So we'll build our own in there. And if you've had, like, you can actually sometimes see this on, like, especially like phlebotomists and stuff like that. Whenever they're going to draw blood on people, you're going to notice that there's a whole lot of variance in people's vasculature. And sometimes you can see these little shunts and stuff that people have made because they're going to have these blood vessels that just run like really weird directions. Or people will have like be in a surgery where they're going to be messing with vascular stuff, and all of a sudden someone's blood vessels are just doing something weird, like blood vessels like cross over for some reason and take 2 different pathways than what they're supposed to, and they just do that on their own. It's kind of strange. Now, so far we haven't really talked about capillaries, even though capillaries are awesome. They are tiny, okay, like just a little bit bigger than a red blood cells. We're talking, so this is 8 to 10 micrometers. That is, so a micrometer is 1,000th of a millimeter. It is little bitty, okay? Little tiny things, okay? Very, 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 very small, okay? Just slightly larger than a red blood cells, okay? Now, most of our capillaries are going to look like this, where we have a continuous capillary. Essentially, we have a single layer of epithelial cells, so of squamous epithelial cells, so simple squamous epithelia, just cell touching cell touching cell touching cell, and that's it. Collectively, they're all meshed together. And remember, the epithelial cells have those tight junctions in between their cell membranes, which means stuff can't get through them. Okay, you cannot pass is essentially what these things say. They're basically creating like a little wall. Large particles like proteins, especially not cells, can't pass through. If you're going to be able to get through the gap in between these cells that are essentially riveted together, you have to be very, very small. So like glucose and gases and stuff like that can do this. Salts can do this, but larger things like cells and proteins can't. So this is what we're going to find in most of our tissues, okay? So they connect the cells, but the seal isn't quite full. Now, our next option is, instead of something that's almost entirely closed, is to open them up a little bit. And the way we're going to do this is we're essentially just going to run little channels through the cells themselves. We're going to call these channels fenestrations or pores, okay? So by having little pores, we can allow stuff to pass through the capillaries. The larger the pore, the bigger the thing that we can fit through the capillary, right? This is what we're going to find whenever we need to be doing a bunch of transport, okay? Or acting as a filter. So just like a coffee filter is essentially a flat sheet with a whole bunch of dots in it, like a whole bunch of holes running through it that determine the size of the stuff that can pass through. The same thing is true of these fenestrations. The larger fenestrations will allow larger stuff through, but we can also regulate those sizes. So we're going to find this in places where we need to move a lot of fluid. Okay. Places like your kidneys, we're going to have these fenestrated capillaries. Places like your intestines, where we're absorbing a bunch of nutrients, a bunch of water soluble nutrients. Well, that means we have to move a lot of water, right? If we need to get nutrients into our intestines, that also means we have to get water into our intestines. So that means we're going to be once again using these fenestrated capillary because these are going to allow movement of some of those smaller plasma proteins that got stuck or had to stay inside the blood in our continuous capillaries. Now, here's a question. Can you think of any times when we might need to move something larger than a small protein? When?
Are blood cells larger?
Yeah.
And then what about white blood cells?
Yeah, for damage and stuff like that, right? Cells. A cell can't fit through this little fenestration, but we have to get cells in. How do we know we have to get cells in? Because our red blood cells only last 120 days, which means we have to have a continuous supply of cells coming in and bad cells leaving. So we have to have some place that has openings large enough for cells. And that's when we get to these sinusoids. These things are effing cool looking. Okay. They look like some sort of alien spaceship to me. Okay. Why? It's so that we have large enough openings that we can get cells into and out of the blood vessels. Okay. Lots of fluid can move across these, but also we can get formed elements like large proteins, your albumins and stuff like that, as well as red blood cells and white blood cells across these membranes, even some of the larger hormones. Because remember how some of our hormones are actually quite large, like 15 or 20 amino acids long. Those things are probably too big to move through those fenestrated capillaries. So something like that, we have to have, once again, one of these sinusoid capillaries to do this. So bone marrow, where we make our red blood cells, we have to have these. Spleen, where we store red blood cells, we have to have these really open capillaries. This just looks super fun to me. Sorry. All right. Now, here we have a capillary bed. Okay. So this capillary bed is basically going to have an arteriole that's going to bring blood to it. And then we have the venous end where the blood is going to drain. Now, importantly here, the arteriole that leads in is going to have some smooth muscle cells that are wrapped around it so that we can regulate flow to this entire capillary bed. But we're also going to have these little tiny, what we call sphincter capillaries here on the outside. So precapillary sphincters. And these are once again smooth muscle that we can constrict. This is going to allow us to either open and allow blood out in here into the capillary bed, or allow us to simply close these and just shunt the blood from one side of the capillary to the next. Okay? Because, like, say we have a bunch of tissue out here that needs more oxygen and stuff like that, or needs has a bunch of waste products that we need to pick up, we open these capillary sphincters to allow the blood out here to pick up all that waste. We get into the veins and then we're good to go. But once we've done that, like, unless we're producing a whole bunch of that waste product right here, we may not need to do that again in the very next cardiac cycle. We may be able to wait 4 or 5, 6 beats or longer to open this capillary bed back up. So what do? We simply close these sphincters and we shut those things off so that we don't have to allow that exchange bit to occur in those sides. We can just allow the blood to kind of get shunted over to the venous side. Does that make sense? Now, one fun thing with our veins is one that they're going to be acting kind of as a blood reservoir. At any point in time, a little over half of your blood is going to be found within the veins. Okay, so 55%. So within your systemic veins, that is a lot. Okay. In the case of, say, like a normal adult, so say we have 5 liters of blood, that means we're going to have a little over 2.5 liters of blood just hanging out in the veins at any one point in time. By contrast, in the arteries, we're only going to have 10% of the blood, which means we're only going to have about this. So about half a liter, which I said is about this cup all the way filled to the brim, would be about half a liter of blood just hanging out in your arteries. So a lot less, 5 times less. The fun bit is that we'll have even more in your heart. Your heart at any one point in time is going to have 12% of your blood. That's a lot. Okay. Now, to make things even more fun, pulmonary circulation, which is to say your lungs, have 18%. Keep in mind that your lungs are basically nothing but capillaries and air. Okay. So we're storing 18% of our blood here in our lungs and another 12% right here. So a third of your blood is in this little pocket inside your rib cage at any one point in time. That's a lot. That's also why any damage to one of those two things means you bleed out now. I have shot a deer where I could watch blood pouring out the other side of it like a ketchup bottle. Like that's not even, I'm not trying to be gruesome or anything like that. It's just like, that's how much blood is pumping through these areas. Okay. Uh, so once you kind of think about it in terms of these sort of percentages, sometimes it makes a little bit more sense. Like, oh, that's a lot. Because like in the case of pulmonary, that's a liter. It's a liter of blood in your lungs. Cool. Mhm. Exactly. We need so much oxygen, so we have to have a bunch of it in there getting oxygenated. Why? So that it can get beat around back to the heart, so that it can get sent out to the rest of the body in that little third of a liter or half a liter, and then on and on and on and on and on it goes. Now, the fun bit is that that stuff is going to change during exertion. We can vasoconstrict in some places to shut blood flow off. So, like I said, if you're going to go run, you're doing a bunch of exercise, we don't need that much blood going to our digestive system. So we tend to constrict those blood vessels so that we're limiting how much blood is going to things like our gut or our kidneys. So those two things will decrease by about half during exercise. Whereas your muscles will increase by over 10 times. That is how oxygen hungry your muscles get during exercise, is that you will increase blood flow to those areas by more than 10 times. Um, So those areas, like your muscles, vasodilate, vasoconstrict in places where we don't need the muscle or the blood to go.
That's the same thing whenever it comes to like rest and digest.
Yep. Yep. Rest and digest, we're going to see a little bit of the opposite. So at rest, we're going to send about 1,100 milliliters a minute to the muscles, whereas that number is 12,500 or so to the muscles at exercise. Versus in the kidneys, like I said, it roughly doubles when you're rest and digest and stuff like that. Now, here's some different blood flow pathways. So far we've seen this kind of simple pathway where blood comes down an artery, enters an arteriole, and then enters a capillary bed, then leaves that capillary bed via an artery or a vein rather, and then back to the heart. Okay, very simple. Well, we could have an anastomosis here where we basically have a network of blood vessels that are carrying blood to your capillary bed, and then that capillary bed can then feed to a single vein. Or we could take a single artery and lead to multiple veins on the other side of the capillary bed. You could also take multiple arteries into a capillary bed and then into multiple veins, uh, for you to have both an arterial and a venous anastomosis. Sometimes we'll have these little shunts get put in place. Like say we have a little bit of a blockage right here. We can just simply shunt the blood across it, right? Like just send it around it as one option. So we can sometimes build our own little shunts in places. Other times you might have what we call a portal system. We have seen one of these before, like when we talked about the endocrine system, how we had the hypophyseal portal system where we had the capillary bed around the kind of pituitary stalk at the bottom of the hypothalamus, and then it led to a portal vein, and then to that capillary bed down to the anterior pituitary. That is an example of a portal system where you have basically capillary bed leading to another capillary bed. Okay, we're going to see another one of these in the liver here pretty soon. Now, importantly, the vast majority of the surface area of blood vessels in our body is composed of our really small vessels, our arterioles and capillaries and venules, especially capillaries. Okay. While they are the smallest individually, we just have so many of them that they make up the vast, vast, vast majority of the overall surface area of our blood vessels. However, that also means we have a bunch of places where we need the blood to go slow. Because remember how we talked about those capillary beds as basically being like our uh, toll booths, where you have to be moving really slow to be able to pass through the toll booth. Otherwise, you can't really drop your money into the basket, right? The same thing is happening here. We can't get nutrients into and out of the blood unless it's going slow. So in our capillaries, our blood has to be going very, 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 very slow. So what has to absorb all of that pace, all of that energy? It's going to be those larger, more muscular blood vessels like your arteries. So the larger elastic arteries and the muscular arteries that have to absorb all of that force that your heart is putting on that blood. Okay. Because every beat, once again, you're pumping over half a liter at a time through a vessel that is that big in its fluid. Okay. Like I said, literally strong enough to hit that wall over there. Don't believe me? Ask someone that's ever been in a surgery before if they've ever had blood get on their shoes. Because someone nicks one of these things or they're going in to repair someplace and they cut one of these things before hemostat's on and blood just goes. Like it's like a horror film. That's not a joke. Okay. Uh, yeah, it's bad. Uh, or like, especially like in like war zones and stuff like that, and people get shot in some of these vessels and stuff like that. Damage to these big elastic vessels cause bleed outs in some cases within seconds. Like a cut to a femoral artery is enough to literally kill someone within seconds if you don't stop the blood flow through it. And sometimes it's pushing with so much force, it'll literally push open hemostats. Yeah, fun times, right? Don't get shot. Now, all of this is once again to get us to diffusion, though. We have to go slow so that we can get enough diffusion, so that we can move nutrients through those blood vessels the way that we've already talked about. All this net filtration pressure, osmotic pressure, this is all going to be kind of physiological concepts. So make sure you're kind of reading those sections really well. I'm trying to mostly stick to the anatomy side of things. All right, now this gets us finally to blood pressure. The reason that we have blood pressure, though, is like we have a really high pressure close to the heart and we have a much lower blood pressure as we get to the capillaries, right? Well, what direction do things move? They move from high to low. So this gives us a gradient that is going to force the blood to keep moving. So this is what's going to help make sure that we're propelling the blood through the vessels so that making sure that we can get stuff where it needs to go. Okay. Now, blood pressure is going to be measured over the span of two numbers. We're going to see this in terms of a systolic pressure and a diastolic pressure. The systolic pressure is essentially going to be the pressure of stretch that is created by that bolus of blood due to ventricular contraction. Okay, so your ventricles contract. This is when the blood is going to be under the most force it will ever be under. Okay, so because of this, we're going to see this little bolus of blood hit that blood vessel, which means we're going to see the blood vessel have to absorb that force via stretch. Okay, so this is what we're calling our systolic pressure. This is basically just the maximal force that the heart is exerting on the blood. Make sense? Now, after that happens, the blood vessel will recoil and it will bounce back to where it was before in size. Okay. This amount of kind of recoil force, or like the amount of force that is open on this, acting on this vessel to keep it right here, is going to be what we call the diastolic pressure. Okay. So this is the minimum force that that blood vessel will be under. So how do we measure blood in this? So essentially what we're going to do then, so keep in mind that these little boluses are going to be moving in one direction, right? So what we're going to do then is we're just going to put a block inside this pathway where we can measure how hard it's trying to stretch. Okay, so that's what we're going to do with a blood pressure cuff. So what we're going to do then is we're going to take this blood pressure cuff and we're going to wrap it around the arm so that we can occlude, in this case, the brachial artery. Okay, so that the brachial artery is basically going to be the large blood vessel running through the upper part of the arm. We're essentially going to squeeze that part with enough force that blood can't pass through it. Okay, And we're going to slowly release that pressure until the heart is exerting enough force on that blood pressure cuff that it forces the blood through. The moment that happens, you're going to go from not being able to hear the blood to being able to hear the blood. The moment that the heart has put enough pressure on the blood to allow it through the cuff, you'll start to hear it. So you'll start to hear the pulse. Okay. When that happens, you have found the systolic pressure. Okay. Because you're going to be slowly releasing the pressure from this cuff. And the moment that pressure gets low enough that the blood can push past it, that is your big number. Okay. You're going to keep releasing the pressure from the cuff until you can't hear it anymore. The reason you can't hear it anymore is because now the blood pressure cuff is no longer putting pressure onto the vessel. Now any pressure inside the vessel is just always there. Okay. You're no longer putting enough pressure to occlude the vessel at all, so you're going to stop hearing the sounds. Okay. Does that make sense? Okay. So what we're going to do then is we're going to measure this. Now, to help us do this, we've got our lovely, lovely stethoscope right here. I'm sorry that the earpieces in these are not the most comfortable.
I have like a pink one.
Oh, very nice. My wife still uses the stethoscope she bought during
Mhm. There's some, because every place that I went and like shadowed and that I've just been to, they always either use the electric ones or they have their own where it like has a screen and it just tells you.
Oh, that's nice. Yeah, we're doing this old school way.
I like those.
It is. It's more instructive. All right. So what we're going to do then is we're going to.
It's a double one.
Oh, yep. So what we're going to do then is we're going to take the cuff here. We've got our line where it says artery, and we're going to essentially line that up with our brachial artery, which is going to be slightly off center. Okay. So the brachial artery is going to run through basically right here, roughly 1/3 of the way from the lateral side. Okay. So whenever we take this cuff, we're going to wrap it on there and we're going to try and get it pretty snug. It's actually hard to get snug by yourself. So this is why you're going to be helping each other do it. Okay. And we want to line that up with roughly that artery. Okay. You want to leave yourself enough space where you can get your stethoscope here under it because you're essentially going to take your stethoscope and place it here. Okay. Now, if y'all want to each grab in. We also have a little valve right here. So right now, because it's twisted all the way to the right, that valve is closed, which means I can squeeze and I'm going to pressurize the cuff. Okay, so we can see that it's holding air. When I release this, that air is going to be let out.
Yep.
Okay. So I'm just going to squeeze this, and I'm going to squeeze this up to enough that I can occlude the blood vessel. Okay, which means I need to be, if everything is going great, I just need to be above 130.
Yeah.
Okay. If someone has higher blood pressure, you may need to go higher. There's nothing like having your blood pressure checked and they go to start releasing gas and like, oh, nope, still can't hear anything. And they have to pump it higher again. That's disappointing. Okay. But that's what we're doing here. So we've got it pumped up enough. And now what we're going to do is we're just simply going to place our stethoscope here kind of near that artery. Now, importantly, we're not going to be able to hear anything right now. We should be able to hear the pulse or anything. And that's because we should be completely occluded. So what we're going to do is someone just wants to hold that. And you want to put some pressure on there. And importantly, do not put pressure on the diaphragm on the back. Okay. Now what we're going to do is we're slowly going to release pressure from the cuff. And the moment you can hear pressure, pulse, which should be the now, you hear it? Mm-hmm. Okay. That tells you that we've met the top number, which was right around 120, maybe a little higher than that because it was sitting there occluded for too long. Until it stops, which it stopped there. Okay. Now, once that happens, you can release the pressure. But y'all notice that it went from nothing, 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 and then I have a fairly strong pulse, so it should have been pretty darn noticeable. Like I was watching the needle move.
Yeah.
Some people with smaller pulse pressures and like lower blood pressure and stuff like that, you may not be able to hear it very well. Like it's gonna be really faint to the point where the only way you really know, like you can hear it sometimes, but sometimes you really just know by watching the needle move.
Yeah, I did see
like it, but it's just kind of wiggling on those people, whereas mine is like twitching because it's moving. There's gonna be some differences there, so that's something to kind of keep in mind too. But that's really it. So now y'all can kind of check each other.
Yeah, we had to do this on a test. It was so scary.
Why?
We had a lab room and it was dark. The lights
Oh,
were like
okay.
off and they were like a little dim. And two of our medical assistant instructors were just sitting in there waiting. Go and do it. Then they'd have the one side on, and then they'd be like, okay, go to the next one, and then you do it, and then you leave, and that's it.
That is kind of nerve-wracking. That does sound a little creepy, actually. I don't know if I would enjoy that. So yeah, go ahead and check your pressures there. And then what we'll do is we'll kind of have y'all walk around and we'll check it again after a little bit of exercise so we can see those numbers are gonna go up.
Okay.
Are we just use one of them?
Yeah, just keep using the same earpiece that you were using before. And y'all will kind of listen to each other. This way, whoever's getting checked, so our patient can still listen. Because it's always good to hear those sounds of cough, as it were. Just that way we kind of know what's going on. Plus, you don't get to listen to heart sounds every day, so. Now, the funny thing is that the best, like this end, the smaller side is actually better at hearing these particular sounds. But the bigger side just gives you a little bit of a bigger surface area to make it easier to find. Go ahead, pump back up. One 30/83, something like that. 130/83 or something. That's about in there.
Like 120.
Oh, it was 120.
Cause like you can see it, cause they always got heavily whenever we do like sort of thing. I haven't done this in so long though. Like a little, when you look at it, because you always go over what you.
Yeah.
But, it sounded like 120, like right under.
Okay. I just saw a flick like right there,
Yeah.
rather than 30 more. So, because I'm just having it based off relook since I came here. Could you hear it on yours?
No.
Not really. So you kind of have to push it. So you can't set it for us. Kind of have to push it a little bit. Because like you're having to get resistance along the membrane. So you kind of have to push the vessel against something firm. So it's sometimes easier to kind of start in and kind of push your way kind of towards the outside, kind of push it in one of those little tendons or the muscle over here.
Can I push it
Yeah.
again? Can you hear anything?
I think I heard a little bit of it 100,
Yeah.
but it was so thin.
Yeah, looking at the needle, it's like 170. But let's try this back.
My blood pressure is really
Also, these are not the best stethoscopes, so
Mhm.
I can feel it too.
Yeah, I didn't hear anything.
Let's go. All right, so y'all go ahead and do a couple laps. See if we can get those blood. See if we can get some stuff moving. And then when that comes back, your pulse pressure should be a little higher, that we should be able to hear it. That is kind of odd though. But it sounds like that's kind of part and parcel with your stuff. So yeah, just kind of walk around. You can walk on kind of the little lap outside. You can walk it in here. It's whatever you want to do. Just kind of do whatever you need to kind of get your blood moving a little bit.
I can feel like
There you go.
And my shoes are loud.
They really are. They're very flat. I think that's the problem.
Yeah.
But you heard mine fine, right?
Yeah, I did.
Yeah, it's always funny doing this kind of stuff. Like it's pretty common for girls for it to be a lot fainter than it is mine. But mine, it's always strong enough that everybody can hear it. Like, oh, I can't find it, can't find it, can't find it. There it is. All right, so here you go.
Do you want to do it so you can hear?
Yeah. Okay. Like, it's very
really
loud.
loud. Wow.
Here, you can. Like it should be like I can't even feel it. So should be pretty darn noticeable. It's fine. Good.
Mhm.
My pressure, I think, was 140/7.
That's definitely more.
It's definitely more, but it's also lower. Like it went from 120/80 to now it's a bigger range. Why? Because we're pushing bigger boluses of blood, right?
Yeah.
So we're pushing bigger volumes. So instead of pushing on average that half a liter, we're probably pushing 750. With a beat.
Wow.
It's crazy. All right, now probably you go next since yours, maybe yours is still elevated, maybe yours is loud enough now.
Okay.
But yeah, so that lower number was higher, or sorry, was lower because we dilated that vessel. Why? To get more blood going to those muscles. Right? So the higher number got higher because we're hitting with more pressure, we're getting bigger volumes, but now we also dilate those vessels to make things a little easier. Nothing?
I can't go.
Oh, you could hear something? Okay,
I
perfect.
did hear something.
Yeah, it's everybody. It's not heard of this, but they always put it the bleed up.
Oh, okay.
I don't remember if it was on the inside of the outside.
But those electric machines, like those electric blood pressure cuffs, are still doing the same thing. Like that's all they're doing. It's just in a self-contained little thing. Oop.
Very good.
It is 122/72.
Yep. So vessels are still dilated a little bit. So, yep, that sounds about right. So as we can see, top number tends to go up, but the bottom number typically will go down because we are dilating. Okay. So that's one of the reasons that we do this is so that you can kind of see both effects. But that's because we're trying to get extra blood to all these tissues. So we have to open this stuff up a little bit. Okay. Now, one of the other big numbers you're going to see on a blood pressure machine is this mean arterial pressure. Okay, so all this means is that we're looking at the average pressure across the entire set. Okay, now the heart is more often relaxed than it is beating. Okay, so because of that, to calculate this MAP number, all we're going to do is we're going to take the bottom number and then we're going to add it to 1/3 of the pulse pressure. The pulse pressure is the difference between the two numbers. So in this case, our example is 120/80. Okay. So 120/80, that means we have a difference of 40. So 40 then is our pulse pressure. So we're going to take 40 and multiply that by 1/3. So that's going to be about 13. And then we add that to our diastolic pressure. That is our number. In this case, we get to 93 as sort of the ideal, or at least average ideal of our mean arterial pressure. What this is essentially saying, hey, we have a number for perfusion. As long as we have a number greater than 60, we shouldn't have any problem with getting enough oxygen to all of our tissues. If that number falls below 60, that means we're going to have some tissues that are going to go ischemic, okay? So that they're going to start running out of oxygen. Now, what you'll also sometimes find, though, is that a lot of people will have lower blood pressures and lower heart rates. Okay. When this happens, their mean arterial pressures, so their MAPs, will not be 93. They'll usually be on the lower side of things. They're still going to have enough to keep all their tissues and stuff like that fine when they're like in that 75 to 80-ish range. But what you'll notice is that we're not going to have that much perfusion in extremities. Hands, feet, they're going to be a little bit lower on perfusion in those areas, which means people with these kinds of lower pulse numbers, like lower pulse pressures, lower heart rates, and lower blood pressures, will tend to not be ischemic, but they're just getting a little bit less pressure in those far extremities. So they're going to be far more likely to complain about their hands and their feet being cold than someone like me who was making the needle jump by 5 or 10 millimeters every time my heart beat. Okay. I have never complained about my hands or feet being cold. Like, uh, for that to happen, it is cold. Like, we're talking like teens for me to complain about my hands and feet being cold. Okay. That is not the case for our people with our low blood pressures and stuff like that. Are like, it's 65 degrees in here. Why are my hands cold? Okay. And that's why. Okay. They have enough perfusion to get their tissues where everything is perfectly healthy, everything works fine, but just not quite enough perfusion to really fill some of those little tiny areas and stuff like that far away. Does that make sense? So a little bit more pressure in those cases could kind of not fix that, but at least alleviate some of those problems. But it doesn't necessarily mean that there aren't other problems that come with that. Now, to help the blood get back, we also have what we call a skeletal muscle pump. So because we have valves and stuff like that to prevent backflow, right? Well, in our veins, we don't have that much pressure in them to keep the blood moving. So sometimes we do utilize either our skeletal muscles to help push the blood through, or even our pressure in our cavities, so either our thoracic or abdominal and pelvic cavities, to put pressure on the walls of the vessels to once again help push the blood through the vessels and get it back to the heart. And that's kind of happening like as the blood is also pumping, or as we're getting these boluses of blood that are helping push those previous ones through. Now, importantly, we have lots of stuff that is going to go into our blood pressure. Now, blood pressure is basically going to be the primary thing that we're using as our force to get blood to get from the heart to everywhere else, okay? And we're using this to kind of create our gradient that pushes that blood where it needs to go. The bigger the gradient, the easier it is to get stuff out into those extremities. Without a larger gradient, that's why sometimes we kind of run out of steam. Now, once again, that's all about getting nutrients and oxygen to these places. Now, one of the biggest things that can lead to our blood pressures, though, is this number called resistance. Okay. This is basically just a measure of like, okay, how much resistance is there to the movement of the blood? We have a few factors that go into this. One of the biggest ones is length. So what is the length of the blood vessel? Okay, the longer the blood vessels, the more resistance we're going to have. Bigger people will have longer blood vessels by definition, so we're thus going to have more resistance and thus higher blood pressures. Okay, if you add to that, that we also have to add extra vessel length whenever we're building new vessels to fit into more things. Like, so say you put on some extra fat, okay? As you're putting on that extra fat, well, fat tissue is particularly vascular. Okay, as you gain fat, you have to build up a bunch of vascularity just to be able to feed those fat cells. When that happens, you're drastically increasing the length of your blood vessels at that point, which means you're increasing your resistance, which means you're increasing your blood pressure. But the opposite of this is also true. If you go on a big exercise routine and you get rid of a bunch of that fat, you no longer need all those blood vessels to keep that fat happy, right? So those blood vessels go away. So that means you lose a bunch of that resistance, which means your blood pressure goes down. That's why one of the biggest things that your doctors will always tell you, like, oh, hey, no, like to keep your blood pressure and all that other kind of stuff under control is like, hey, just try and lose a little bit of weight. And that will go a long way. Why? It's because we're getting rid of vessel length, which means we're getting rid of resistance. So that's what we're going to use to pull our blood pressure down. Does that make sense? Now, viscosity also plays a big role here. I showed you all that picture of the blood or of the bodybuilder blood last time, right? Like where it's so thick it kind of got stuck in the glass. We don't want, that's very viscous blood. The more viscous the blood, the harder it's going to be to move through the vessels. Okay. Because, well, that's just going to be harder to move it through. It's like pushing jello. It's just going to take more force. That means we're going to have higher blood pressure in that case, which means oftentimes in the cases of that bodybuilder, we have a big increase because of blood doping. So we have a really high cell count. And in that case, we're also dehydrated. Okay. Because they're typically getting prepared for competition. They're trying to get out a whole bunch of water so they can get really, really, really lean. When that happens, they're very dehydrated. Their blood count, cell count is super high already. So all of a sudden, their hematocrit gets to like the 70s. That's a lot of force or a lot of resistance on the pressure of that blood. So their blood pressure is going to be very, very high in those cases. Usually people that are on those kind of drug loads for bodybuilding and stuff like that will also have, as part of their like pharmacy that they're taking in addition to the steroids, will actually be a blood pressure medication to help keep their blood pressure down a little bit so that they don't just like break all of their capillary filters and stuff like that, and stuff like their kidneys and stuff like that, because of having really, really high blood pressures, because it's that bad for you. So just think about how bad this situation is. Like, okay, I'm taking all of these testosterone kind of increasing things, so much so that I have to take a blood pressure medication just to deal with that particular side effect. Sounds like a great idea. Just great. Huh? Yeah, that's also why some of these people die from, like, that's not a joke. That's literally, like, this is very common for people, like young, incredibly fit people that do bodybuilding and stuff like that, to run into massive cardiac problems because of this kind of stuff, to the point where 25 and 26-year-olds can pass away from heart attacks and stuff like that because of this. Not ideal. Uh, see what else. Bulk flow. Now, once again, we can also regulate those blood pressures by vasodilating or vasoconstricting. So our arteries have muscles, right? Which means we can dilate these things to lower blood pressures, or we can constrict them to increase blood pressures, or use that to adjust flow to particular places. Now, we do have to regulate our blood pressure. We try and keep our blood pressure within a fairly normal or a fairly narrow range. Okay. It has to be high enough that we get oxygen flowing to our tissues, but not so high as that we blow out our coffee filters. Okay. Just like the reason I keep saying coffee filters is because, like, I tend to think about things like the capillary walls in our kidneys as well. It's a filter. So I think about it like a coffee filter. So like if you take a coffee, like a paper coffee filter in your head, and you put some coffee grounds in it, we want the coffee grounds, i.e. the blood cells, to stay inside the coffee filter, right? Well, if you pour water gently into the coffee filter, water goes in, and then little, like, we dissolve coffee particles, but not coffee grounds. And we have brown stuff come out here that is the lovely part of coffee, but the grounds stay in the filter. That's what we want, right? But what if you take that same coffee filter and you dump a water hose into it and you crank the water hose up? What happens to the paper coffee filter? It rips. That is what we don't want. Little tiny tears that even allow the coffee grounds through. It's bad for your coffee. It's not fun to kind of chew on the coffee that you're drinking. Okay. And I love coffee, but even I don't want to have to chew my coffee in the morning or during the afternoon, or literally midnight. It doesn't matter. I'll drink coffee all day long. You think I'm joking. I literally had a cup of coffee yesterday at 10 o'clock. It was decaf, but coffee's great. It just tastes good, man. And I buy good coffee too. Like the coffee that I'm like, my decaf coffee is from Colombia, but the coffee that I had this morning is like a really cool one from Uganda. So it's like a natural process thing. That means they pull off the beans and they let them kind of ferment on their own. So it's kind of got this kind of fermenty sort of flavor to it. It's great.
Were you able to sleep?
Huh? Yeah. Yeah. It's fine.
Okay.
Oh, I mean, it's decaf. So like, so it's all
Oh.
good. But yeah, love coffee. But we have to regulate this stuff because we don't want it so high that we break that coffee filter. Like, we need the coffee grounds to stay inside the filter. Otherwise, really bad things happen. Okay. So that means we need to regulate that within that fairly narrow range. So we're going to do this in a lot of ways. One of the things that we have to do this are, of course, going to be some reflexes, and it's all going to be controlled by our medulla oblongata. Once again, the cardiovascular center of our medulla oblongata. So we're going to do this in one of two ways. We can accelerate things. So like, say we sense that oxygen levels are getting low, or that pressures are getting low. We can increase cardiac output and thus increase increase blood pressure to increase heart rate, increase force of contraction, so that we can get higher pressures and get more output, right? Because things are low. Or on the opposite side of things, say you eat some really nice quesadillas and you're going to sit down and watch a soccer match. Okay. You don't need to be all that active. So what are you going to do? You're going to slow down. heart rate slows down, everything slows down. You get more blood flow down here to digest all of the lovely quesadillas. Okay. And then you're relaxed. So we use the cardio inhibitory center to bring everything back down. Quesadilla sounds really good right now. That's part of why I said it. I had chili for lunch, and it was good, but now I'm like, man, I could go for some quesadillas. I love food. I love food so much. I actually make a very good Mexican rice. You toast the rice first. That's the trick. You have to toast the rice first, otherwise it doesn't work right. Also, if you're making cilantro lime rice, put some bay leaves in it, like when you're cooking the rice part first. Take them out before you add the lime at the end. But yeah, it's the bay leaves go a really long way into making it taste better. So hungry. But once again, we're measuring all of this stuff using our baroreceptors, which is to say pressure receptors in our blood vessels, as well as chemical receptors also in blood vessels and in our tissues. Now, what are some of the ways that we can, so we use the cardiovascular center, which is a nervous control, but it's nervous system control, which means that's going to be better for short-term control. That's for like figuring it out right now. That's not for figuring it out 10 minutes from now or 2 days from now. Okay. If we're going to do that, instead we need hormones. Okay. So our hormonal control, one of the biggest places that we're going to get hormonal control is going to be from the kidneys. This is because they're constantly monitoring the blood at all times because they have to protect their little tiny coffee filters. Okay. Because they're protecting their little tiny coffee filters, they know what pressure is happening in the body at all times. Okay. Which means they are perfectly positioned to regulate the blood pressure because they also control how much fluid gets left in the system. Okay. So not only are they actively monitoring, they're also regulating the biggest thing that we can do to control it. Okay, so that means they're the perfect place to control the system. Okay, so one of the biggest things that they're going to use to do this is a protein called renin, or the hormone called renin. So renin, R-E-N, ren, like renal, like kidney. Okay, now this is going to be part of what we call the renin-angiotensin system. Okay, or RAAS, RAS. Okay. So angiotensin also tells you what it does. Okay. Angio means vessels. Tensin means to tension, like tighten or constrict. Right. So angiotensin is going to be a chemical that's going to cause constriction of the blood vessels. Well, what do you think is going to happen to your blood pressure if you constrict your blood vessels? Going to go up. Exactly. So the renin-angiotensin system is particularly good at raising blood pressures. Okay. So say the kidney realizes that blood pressure is too low. When the kidney recognizes that blood pressure is too low, it's going to release renin. Okay. Renin, so will get released from the kidney and it will act on this hormone or this protein in the system called angiotensinogen. Okay. Remember that ogen means origin or to make. Okay, that's what ogen means, right? So if it is angiotensinogen, that means what are we making? We are making angiotensin. Okay, this is the precursor molecule to angiotensin. So renin is going to act on our angiotensinogen and basically turn it into angiotensin, which has our first stage. So we're going to call it angiotensin 1. Okay, that's why it's RAAS. Okay, angiotensin 1 is the first A. Our next one is angiotensin 2. The way we go from angiotensin 1 to angiotensin 2, ow, I just shocked myself, is through a hormone called ACE. So this stands for angiotensin converting enzyme. Okay, so angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2. Okay, so it converts first form into second form. This one is the one that's actually going to raise your blood pressure. This one causes vasoconstriction. Angiotensin. Okay, so tenses your blood vessels. Well, we do that and we increase blood pressure. It also causes us to release aldosterone and antidiuretic hormone. Okay, those two things cause, well, antidiuretic hormone, so diuresis. That means to get rid of water. Antidiuresis means not to get rid of water. So it causes us to hold on to fluid. Well, if we are constricting, so say we are holding on to more fluid, that means we have more fluid in the same space, which means we have more pressure. So we have increased blood pressure again. Aldosterone stimulates our thirst center, so you drink more water. So not only are you taking in more water, you're getting rid of less. So you're increasing blood pressure again. So we're constricting vessels, increasing blood pressure. We're stimulating thirst. So we're taking in more water, increasing blood pressure. And we're decreasing the output, which means we're increasing pressure. Increase, 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 which means when ACE is working, we have a much increased blood pressure. Okay, all because our pressure would be too low. Now, if a patient were to go into their primary care doctor, they check them on a blood pressure cuff and they check them and it's consistently 140, 150, 160 over, I don't know, 110, 120. That's really high. And say they're talking to their doctor and they're like, like, I am stressed, but I'm just always thirsty. Like, I feel like you're like, how much water? He's like, well, I drink a bunch. Like, I don't see how I'm thirsty. I'm drinking 2 or 3 or 4 liters of water a day, yet I'm still thirsty. Why would they still be thirsty? Probably because they're overproducing aldosterone, right? And if they're overproducing aldosterone, well, that means their thirst stimulation is high, so they're constantly taking in more water, right? Well, why might they be doing that? Well, maybe they have too much of this ACE enzyme. So those kinds of patients are going to be given a special class of drugs that we call ACE inhibitors. Those ACE inhibitors stop this. So they prevent us from producing angiotensin II. So we lower those people's blood pressures by preventing this conversion. Okay, which means, well, we're not constricting their vessels, we're not stimulating their thirst center, and we're not stimulating them to not go to the bathroom, which means we're lowering their blood pressure, lowering their blood pressure, lowering their blood pressure. And that person with a single drug can bring their blood pressure down to 120/80 pretty simply from their simple drugs. Now, I am on a different kind of blood pressure medication. I'm on what's called a beta blocker. Okay. Mine blocks the beta androgenic receptors. So when we talked about hormones the first time, or like in chapter 17, one of the ones that we talked about was epinephrine and norepinephrine. So those are released from the adrenal glands, right? Those increase heart rate and increase blood pressure. Okay. My resting heart rate used to be in the 90s. It was high all the time. Okay. I mean, all the time. I could literally be sitting there half asleep, like, or actively sleeping with a heart rate in the 80s. Okay. My heart was always really high. I could pop a 101-degree fever, 102-degree fever when doing exercise. I've also seen 190 beats a minute on a heart monitor during exercise. Okay. That is too high. So my blood pressure medication slows that down. My blood pressure medication says, hey, I probably have too much adrenaline and stuff like that in my system all the time, or at least I'm too responsive to it. So I have too high of a resting heart rate, and that is what's keeping my blood pressure high. So I have a beta blocker, which blocks my receptors to things like adrenaline and norepinephrine, which means that is what I'm using to keep my blood pressure and stuff low. This part's probably fine. Okay. Now, that tells us that or hopefully illustrates that we have lots of different things that can cause problems with things like blood pressure. Okay. It's a multifactorial thing, which means we have multiple ways that we can influence it to be high or low. Okay. Now, the fun bit with this ACE one, though, is that ACE is in the lungs. Okay. Now, particularly, it is going to be found in the capillaries inside your lungs. And that's where it is doing all of its activity. During COVID, when someone gets COVID, it is actually going to utilize a very similar receptor on these cells to the point where it's actually going to interact with these ACE enzymes on the outsides of these cells in the lungs, which means we're going to get more of this. So folks, whenever they got COVID, would make a lot more angiotensin II. So people with uncontrolled high blood pressure, particularly in these cases of folks that had uncontrolled high blood pressure due to overactive ACE enzymes, would spike blood pressures in the 200s and die. A lot of the people that died, especially fairly early on in the COVID pandemic and stuff like that, or people, one of the big reasons why people that had high blood pressure were the high risk group for death or long-term consequences and stuff like that were from COVID were particularly due to this interaction here. It would increase the amount of ACE that we were producing, will vastly increase the amount of angiotensin 2 that was getting produced, and then all of the other downstream effects of angiotensin 2. So this is what was causing those kinds of folks to run into issues to the point where they could die. Fun time. So yes, COVID was literally giving people like strokes and stuff, or causing people to stroke out. Fun. All right, so aldosterone is one of the other hormones that affects this. Aldosterone causes us to, essentially causes us to drink more water. Actually, no, sorry, that's a different one. Aldosterone is going to be the one that's going to cause us to decrease urine output. Okay, so basically it says, hey, stop doing this. Hold on to your water. Okay, so by doing this, you're essentially going to hold on to more sodium ions, and wherever sodium goes, water will follow. So if you're holding on to sodium ions in the blood, water will stay there with it. So blood pressure is going to stay high because fluid levels in the blood are staying high. Okay, and when that happens, you're also going to be decreasing urine output. The same thing goes for our antidiuretic hormone. Antidiuretic hormone is also going to cause vasoconstriction and water absorption in the kidneys. Okay, as well as stimulating our thirst center. Fun stuff. Now, if we need a hormone to bring that blood pressure down, this is where we have atrial natriuretic peptide. So the atria of the heart can tell when the heart is getting too much pressure. So there's too much blood being moved through the heart. So it's like, hey, blood volume is too high because we're getting too much stretch in the atria of the heart. So because of that, they will start to release some of this hormone so that we can decrease that. So that these are going to cause vasodilation, which decreases resistance and thus decreases blood pressure. Increase urine output, which lowers blood volume, which by extension lowers blood pressure. Okay, so you should be seeing a bit of a theme. That little machine we just used is a sphygmomanometer, which is just a really fun word to say. Now, you'll often find that there are people with hypertension. This is going to be any time from having systolic of like sustained systolic pressures of 140 or above, and or diastolic pressures over 90. Mine was typically in that 90 to 100 range, so thus I'm on a blood pressure medication, and have been for over a decade. And when I first started taking blood pressure medication, I was actually still relatively fit. And I was still already on blood pressure medication just because of a high diastolic. The top number was always fine. It was just the diastolic number was just sustained too high. And pulse pressure or pulse rates and all that kind of stuff were just too high. And we don't want this. We don't want arteriosclerosis. We don't want thickened walls because thickened walls can lead to hardened walls, also just leads to potential damage down the road. We don't want that. Hypotension is kind of the opposite of this. This is where we have chronically low blood pressure. Dizziness tends to be a big one with these folks. Like they stand up and have like a big bout of dizziness to the point where they can fall, or they can even faint just from the big drop in blood pressure that happens whenever they stand up. So that can be something to kind of keep an eye out for. Sometimes these folks will typically only have those kinds of issues like when they are standing, where they can typically regulate it outside of that. Here we have that difference between exercise. Look at the difference in blood flow to the heart. So heart will get 3 times more blood during exercise. Skeletal muscles will get literally 10 times more blood. The skin will also get 5 times more blood. Why do you think the skin is getting 5 times more blood? Perfect. Exactly. So we can cool off. We're getting that blood to the outside so that we can let the outside environment absorb some of that heat. Very, very good. Also notice that the brain gets more blood flow. That's fun. You may have heard people talk about how if they're not exercising regularly, how they feel like they get some brain fog and they can't think very well. That's actually part of why they get used to this extra blood going to their brain. And this extra blood flow to the brain will actually kind of stay there for a little while after exercise as well. So that is some effects that they can actually notice over time too. But also notice that our blood flow to our kidneys and our abdominal region go down by half. or more. Okay. So that's a big difference too. So big increases in blood flow to the skin, the muscles, and the brain, as well as heart, while we decrease blood flow to like visceral organs like your kidneys and abdominal stuff. Here we have pulmonary circulation. We're going to talk a lot more about pulmonary circulation when we get to the lungs. Just know that we go from pulmonary trunk to pulmonary arteries to pulmonary capillaries, which are out here. And then we're going to go into pulmonary veins, and then finally into the left atria, left ventricle, and then out through the aorta. So we're basically just adding a few things in that little span in between. So arteries, arterioles, then capillaries. All right. Now, this leads us to some more anatomy stuff. Lots and lots of blood vessels that we're going to need to know. There's a bunch of stuff on this figure right here that you do not need to know. I gave you the list. Learn the ones on the list. Do not learn everything. Just learn the ones on the list. Okay? This looks a lot more scary when you think you have to know every single one of these. Okay? Another big thing to keep in mind, these are all going to be named with where they are. If it's in the armpit region, it's going to be axillary. Is it an artery or a vein? Just look at what color it is. Okay. There are a few times when arteries and veins will have different names. Like they're going to have a great saphenous vein in the leg that we don't have in the arteries. The jugular and carotid carotid are going to be the arteries in the head and neck. Jugulars are going to be the veins in the head and neck. But outside of those, they're all going to be the same. Okay. Phrenic means it's dealing with the diaphragm. Mesenteric means it's dealing with the intestines. Look at your roots, okay? Look at your body regions. Everything will have the body region or some sort of clue in the name. Brachial tells you it's arm. Medial tells you it's in the middle. Ulnar tells you it's on the ulna. Radia on the radius, and so on and so on and so on, okay? People get hung up on this. For some reason, people think this part's hard. If you have learned your body regions like I hopefully encouraged you to do last time, this will be a lot easier, okay? Look at where it is, remember the name of your body regions, and you should be good to go. Okay. Same thing with the veins. Yeah. So all of this, there will be clues as to exactly what's going on here. And like I said, there's a bunch of stuff on all these figures that you don't need to know. So just focus on the ones that are labeled on the figure or in the list. Okay. All right. So I'm not going to go through all these. Oh, here's a fun one though. We have a little anastomosis right here in the brain. This one is going in a little circle. So we call this the cerebral arterial circle or the circle of Willis. You don't need to know the names and parts and the pieces of the circle of Willis just because I'm not mean. They are fun, but that's what it is. It's basically this little circle right here around the pituitary gland. Then we've got the veins and all that fun stuff. Here we have probably my favorite structure. It's gonna be this look right here. This is called the conflux of the sinuses or the confluence of the sinuses. It's essentially where all of these sinuses kind of pull together. I don't know why, I just find that fun. It's just a cool word. All right, so yeah, there's a bunch of these. If you try and make your own little ones using just the terms that we use, that's a great idea. Basically like little maps where you can draw yourself kind of where things are going, like this leads to this, leads to this, leads to this. That is a great way to study this stuff, is making your own little charts like this. It really drastically simplifies things. It also really kind of helps you figure out kind of where things are going to be, and you can usually figure it out going from there. Does that make sense? This is just one of those things that's hard for me to teach to you because it's really just time to spend time with it. Look at where it is. If you look where it is, you should be good to go. Any questions? No? All right, then let's get to it. There's still about 20 minutes in class today. If y'all want to keep working on this stuff, you can.